What are your plans?
You mean retiring? Yeah.
He's not going to ever retire.
No, I am.
Yeah, that's
In May.
In May.
Yeah.
And
Yeah, my lease is up, and I don't want to put my name on another
Are
lease.
you taking a long cruise?
I no immediate plans. I certainly plan on traveling some. How about you? You got plans?
Oh, well, yeah, eventually.
Or you got another trip lined up?
No, nothing. You did a barge trip, right? And
No, I never did. My sister did, and she thought it was pretty cool.
Yeah.
You're talking about the canals?
Yeah, canals or Rhine River or something like that.
Yeah.
They'd ride their bicycles to the side edge, and they could jump off and on the barge. They ran the barge, I think, themselves. You know, went through a whole bunch of locks.
Yeah.
They went through,
Which is kind of fun. But
yeah. You know, Jim is my brother-in-law's boater, so he did it that way. I think I'd let somebody else drive the boat, though.
Yeah, I mean, this last trip we did 2,000 miles in 9 days in Spain, and it was a bit much.
A bus?
No, we drove.
Yeah. I've done a bus tour in Spain, and I liked it.
Yeah, bus tour is great. I've done a bus tour too.
You know, they give you lectures while you're on the bus.
Next trip I
feed
do.
you, and all this kind of stuff.
Next trip I do is either going to be a barge trip or a cruise trip, you know, where you just sort of park yourself, or another Rhodes Scholar trip. Those are great.
ROAD.
Yeah.
Yeah.
I went to Cuba with them, and you know, you go to the airport, you give them your bag, and that's the last you see of it.
What'd you call it?
Rhodes
So
Scholar.
R-O-A-D, Rhodes Scholar.
Oh, it's all right. I haven't heard that.
Yeah.
Oh,
It's
fantastic.
the old elder hospital. Cruise.
Oh, is that it?
Yeah, they changed the name.
Oh, right, check it out.
It's really good. They have you know, guided trips all over the place.
And the other one that you might want to look up is OARS, O-A-R-S.
What's that?
They,
Same thing?
yeah, I mean, I used them when I was, spent my 3 weeks in the canyon, you know, in Doris. It was unbelievable.
In Kenya?
In the canyon.
Grand Canyon.
Oh, Grand
Yeah,
Canyon.
3 weeks.
Yeah, no, I did a 8 or 9 day, or 3 weeks, a long time. You went all the way to Lake Mead then.
Yeah, from there,
Yeah.
from the dam to the
Yeah, you know,
to
you
the lake.
did. Yeah, no.
But what
and
was
that-
nice is, you know, every day you had your breakfast, and I swear to God, they planned this. Okay, within a half hour, you're in a rapid and you're wet, and the whole rest of the day you're wet. The whole rest of the day, and at about 2 o'clock or 3 o'clock, you pull over to a sandbar or a whatever, and as they're unloading everything, you take them on a walk.
Yeah.
And I mean, there are meadows and there are chard fields and there are.
Yeah, no, I agree, and that's one of the bucket list trips. I think the Grand Canyon, floating the Grand Canyon is one of the great trips you've ever did.
Yeah, so oars, and they do Galapagos, they do everywhere.
Mhm.
So, you know, that's another one for you to kind of look up a little bit and see what
Well, I am a cruiser. I like the boats and being pampered, either river or ocean. But
Well, you're not going to be pampered in the river. I mean, you will be pampered.
well, you remember I had cowboy coffee every morning. You know what? We even had ice cream. 7 days in, we had ice cream.
Yeah.
How do they keep it cold? You know, your own booze. You keep your own. You brought your own, but
Right.
keep it cold. You use the water and be dragged behind the boat the whole way because the water was cold. You know.
Well, what we had, if you don't mind,
Yeah.
we had, there were 4 dories, and 2, like support rafts. And the support rafts were,
Oh yeah. Those are big things. About steering that. Wow.
and it was like,
Yeah.
you know
Yeah.
what I'm saying?
Yeah.
You know, you don't want to mess with them, because they'll break your back.
Yeah.
But they did fantastic things. Every now and then they'd go in front of all the doors.
Just for our.
And then they'd do this circle thing and everything else, and then they'd disappear behind you, and
Yeah.
they'd pick up everything.
Yeah,
When
I
we
will
were
do
done,
that.
every day, they would rake the sand.
Yeah.
and pick
Is this
everything
low
up.
enough
The only thing you ever saw was, you know, the tip of the dory mark.
You know, the first we slept in cots. A sleeping bag on a cot. Is that what you did?
No, sleeping bags on the ground.
Well, I slept on the ground the first night and I woke up and I'm looking at a scorpion eye to eye. And so after that, I slept in the cot.
No, that I would do too. No, we went in the fall. It was, we had Halloween actually, out on the river. Brought costumes.
Did they?
We did, and we all dressed up. It was that kind of thing.
Yeah, no, it's a kid.
Yeah.
No question.
Seriously.
You know what? I keep busy. Got 2 places to keep up, and you know me, I like the yard work. I admit I can't do that much in the winter time. You know, obviously love to travel. I like to read.
Right.
You know, so I think I can keep busy. And I got grandkids too now. You know that kind of stuff. I hope not. I don't think so. I do have to keep busy. You know, I have to keep busy.
That's one of the things that. Okay, slump and call on my friends.
No, you know, and I wouldn't mind working a little longer, but I don't want to put my name on the lease. And here's the other thing, though. Nobody's going to want me. See, group health's not going to want me because I don't do electronic medical records, and I don't want to. And I don't want to look at You could give me a scribe. You could give me a scribe.
Small dog, it's a new trade.
Drew could be my scribe.
No,
Actually, some of the
Yeah, that's what I'd have to do. If I was going to work in a big organization part-time or something.
so I'm talking to David Oka, and he's trying to figure out how to do all this, okay?
Did they discharge?
Dave. Yeah. So he hires a scribe,
They discharged.
because he thought that he would have more time, and then he realized he had to take an extra patient to pay for the scribe.
Oh, yeah. No,
And
scribe
then
cards.
he has to read all the things anyway, because they come under his name.
He said it wasn't worth it.
Did they figure out she?
Yeah.
I don't know.
Is he still working?
Yeah, it's still-
I keep hearing he's retiring.
It's between he and I and Jeff DeMay. One of us is going to retire.
What about Anderson? He's got a full-time practice.
Yeah, but
Still pooped out from the ordeal.
I think that's.
What was it, stem cell transplant?
Pretty confident I look into the child.
and, you know, what's beautiful is the wife takes very good care of him.
What?
And you just, he's stressed, you don't see it.
Oh,
Yeah.
You know, that kind of thing, which is really, and that kind of thing.
I haven't seen him since he was sick.
That's what I'm saying.
looks very
You know,
soft. Is that not?
he goes great, and then it's kind of like,
No, I'm impressed that he's. Yeah, I think everybody did.
you know, I think it's the same for Jeff DeMay.
Yeah, just a little back surgery. Huh?
That much
Getting infected. I have, you know the whole story. Obviously, you're hanging with him. But, he got a complication of infection with a surgery twice. Yeah,
Twice.
but he's still practicing.
Yes, about 3 days a week, 3/4 days, and he's trying to figure everything out.
Yeah,
Yeah.
I can't remember. But he's close to the same age.
All of us.
Is he like late 60s then?
Yeah, somewhere in there.
Somewhere
Or
else,
mid,
okay.
mid if not late. And he's been a powerful man.
He used to be. What you're saying.
Yeah.
Yes.
And did I take your spot?
No, he's this is his
This is
reserve
his
seat
spot.
right here. That's Al. This is mine. Let the old senior citizens have their seat.
Give me your hand. So I'm seeing him the other day. That's all I did.
What was that?
Don't you?
Yeah.
So he's off. All of his, you know, he's got terrible problems. He knows now that it's time to let
There's a lot of good luck and bad luck in this.
So I think he works when he can work. He's got actually, the truth of the matter is, he tries he doesn't get out of the
You got motion.
yeah, I mean, he doesn't get out of the book.
Usually you just leave this, or do you? Are you usually focusing or racing?
Well, you take the boat and then you go to a sandbar or gravel bar and then you get out and, you know, you walk and everything else, like get back in. And,
You know, walk around slippery rocks and all that.
well, that's it. That's what I'm saying.
Yeah, I was gonna say, it'd be high risk.
Yeah.
It's high risk for the rest of us, because I've slipped plenty of times with my waders. And I don't even fish that much, but.
But you know, it's,
Yeah.
things are changing.
That's why I live for the day. Absolutely.
Hit her with a token injury?
You've done all your regular meetings, right?
I'm pretty good, actually. I had shoulder surgery, but it's working okay. You know, I can have full range of motion. I have no pain. It's not maybe a week.
So, rotator cuff.
Right, yeah, and it was my dominant arm.
3-year-old. How did you injure? I don't remember you.
You know what? As a wear and tear phenomenon, I think it was one of those things where over the years I just had one red left. I was just throwing it both getting crap. At our place, and I'm pulling hard, and I didn't even notice it at first, but then I got on the shore, was throwing baseball,
Oh, well.
and all of a sudden it hurt. And then that night, oh, and then after that I couldn't raise it over my head. And you know, the pain at night, that's the great motivator. You know, it's okay in the day when gravity is holding me down, when it's like a tube all night. Yeah, I was kind of you know, I did it in October. Well, I was able to work the whole time because I was in a sling, but I could write.
As long as you were right, you could work.
And so I was able to get by with it, and it took about 6 months to get my strength.
I believe it.
Yeah,
Did you want to sit here, sir?
his reserve seat is there.
So what you see your pride?
Yeah, my pride seat. See, nobody took his seat.
Yeah. No, it's his. Some will probably on the bottom has his name on it. But, no, it's, yeah.
Board? You know, it's a good question. I could be, and you know, I like I said, I wouldn't mind working for somebody. I don't want to put my name on the list, and I have to work for somebody else.
Yeah. And when is this coming out?
That's May. End of May.
I'm looking for somebody to go up to
In fact,
Alaska.
I might need some help from January to May. Do you want to work?
No,
It's not no EMR.
Well,
I have a license in the
I asked them if you could go up to Alaska and take a practice on this.
Well, you can do local tenant, so, but again, I don't do EMR. I think I need to do EMR. Up there in Alaska, there's no
Allergy,
paper.
immunology, correct?
No, I bet she
you still use
Is that right? There is.
Yeah, she probably
A troglodyte. Yeah. But, so, and like I said, I could do something like that, less than 10. So.
I'm still looking for somebody. If anybody knows anybody wants to go up there.
Okay. Is it part-time or
No, it'd be like 2 months.
2 months?
she's getting.
She's got twins. I mean, she just wanted to, close down her practice.
Who's this again?
This is April Ajanu.
April, I don't know.
And which city is she working at?
Well, she's down in the valley. I love the face. Like less than an hour.
The room's actually
Out of where? Oh,
Lovely lady. Great.
when does she need the 2 months?
I think November, December, and January.
I was going to say summer. That'd be nice.
Well, that's the problem she's running into right now, too. But great practice. I mean, really. No, he actually has a clinic there once. Not himself. It's like a barbecue. He was on the autoimmune.
So no, March 13th.
And they thought they cleaned it up.
you just texted me through.
Probably warmer to clean it away, so
Still my license?
about an hour. It's just all crap. They had to actually clean them up. And,
Yeah, he was hospitalized a long time. Like a month.
yeah,
He used to sleep.
oh, more than that.
More than a month in the
So
hospital.
you can't come back to practice.
He is.
Just started he prepared for an hour. He's taking, because of all the pain that everybody else that goes on, everything else, he's taking his time. You know, he has his partners, kind of double check everything. He's doing only his own patients.
That'd be miserable. I've had back fracture from time to time, and that is the biggest nuisance in the whole world. This is world class. It was bad enough. Very depressing.
I mean,
to
he
have
actually
back
had.
What, you had a catheter? No.
Yeah.
Okay, for antibiotics.
I thought that's I really did. And there were times that he said, that's what I
Did you get a fish in this?
It was mostly because I'm trying to just catch up on things. What's going on. Hopefully next year. No, fly up, fly back.
Chuck's with us a lot. I go to the gym and catch him. And he makes good money out there.
In the summer.
No, he goes year round. Yeah, he does it for, I think, like 4 days every 2 months.
Yeah, I mean, it's haters, right?
Yeah, and he sees a ton in a short time. I'm sure he does. He's not having fun.
I think Teresa Nina.
She goes there, son?
But I know I
I didn't know that there was any competition, so there is.
I don't think it's called.
Yeah, no, he built a very good, viable practice.
Yeah.
Probably need somebody to take it over. That's just it.
Well,
He'd probably like to sell his patients.
he's done. He's hired a respiratory therapist, and he's put in a chamber.
The word of the day is guidelines. So I think a lot of you know Ian. He's been here 3 years, came to us from Stanford. He's basically Greg's counterpart. And they're both absolutely incredible. They see the toughest cases from non-allergic, allergic rhinitis, and nasal polyposis. And we have a dual clinic, actually, a severe sinus clinic that we man on Mondays, and it's been incredible for the patient access. And if you don't know Ian, get to know him. He's an incredible resource, and looking forward to the talk today.
Thanks, Drew. It's always a pleasure to come, interact and speak with you guys. A few years ago when I was finishing fellowship, I was out on the interview trail, and I was interviewing with a chair at one of the University of Texas hospitals, and he says to me, congratulations on getting into your fellowship. This is a very rewarding, enlightening career. You'll make, very important relationships throughout your career. But the allergists are going to cure sinusitis. So what are you going to do? And it was a little bit stunning to kind of hear that, and I hope there's truth to that, and I think there's truth to that. But moreover, what it's made me realize is just the importance of the collaboration as a group. That sinus disease is a disease that really requires multidisciplinary care, and it's been so rewarding to work with the Allergy. I think it's really benefited our patients immensely. So what I want to go through today is we've had some recent shifts in guidelines in sinusitis, at least in the ENT space, or more specifically the rhinology space. And this was really a momentous effort on behalf of many rhinologists and allergists included around the world. And so this guideline was published in February of 2016, and I'd like to share with you some updates that have come out of that. And then emphasize what we've done as a group to really respond to that, and as well as medical management, also surgical management. And this is the face of Rhinology. You probably may have heard some of our names, but may not know all of us. But from left to right next to me is Dr. Ernie Weinmuller, then Jamie Litvak, Greg Davis, and Chris Moe, and we represent the Rhinology community. And Greg is locally famous for his sinus surgeries on gorillas, and I wish I had an equivalent story that I could share with you. So there'll be no stories from Woodland Park Zoo today for me to share with you, but I do want to share with you a story of one of my patients who has been really a personal hero for me, and she's taught me a lot. And when you first look at this picture, it's kind of confusing on what's actually happening. But what if I told you that this patient has chronic sinusitis, bronchiectasis, extraintestinal manifestations, inflammatory bowel disease, and was on a lung transplant last 6 months prior? And what you can kind of make out is the patient is in somewhat of a kneeled position, and maybe somewhere near some rocks, and maybe there's some trees below. But what if I told you that this is on the nose root of El Cap, and this was a 5-day climb, 4 nights on the wall, and what we had to figure out was her severity, her chronic sinusitis was such that she really was dependent on topical antibiotic irrigations and steroid irrigations in her nose, and for somebody to reach in her medical comorbidity, peak performance status, to climb this route was a very concerted, collaborated effort amongst many departments, including allergy and the UW management of chronic sinusitis and inflammatory disorders. And how do we get her therapies while she's on the wall for 5 days? And so really what we ultimately figured out to do, and this is her actually doing one of her sinus therapies up on the wall. And so this picture means a lot to me because it really represents, her, testament and will to just move forward and endure this and achieve her goal. And what we ultimately came up with was the problem was, how do you do an irrigation at several thousand feet? And that's carrying the salt water, that's carrying the bottles, that's carrying the supplies. And then how do you just physically do that when you're at altitude? And so what we came up with when we worked with some compounding pharmacies was how to make antibiotic and steroid gels. And so these were preloaded syringes that she was doing at various time points on her trek throughout the wall. And I'll come back to her story in a little bit towards the end of the talk. But what I want to go over today with you is kind of current concepts in the pathophysiology as well as the diagnosis of chronic sinusitis, touch on some of the emerging contemporary treatment models, whether it's medical and surgical, and emphasize more of the surgical, given that you're the experts in the medical aspects of this disease. And then share a little about where I think the future is going in chronic sinusitis. So what it all began with was a guideline in 2007, and this came out of the American Academy of Otolaryngology. And this one of our thought leaders in our field was Dr. Rosenfeld, and he's a general otolaryngologist, but a very intellectually minded, academic-minded individual, and really heads our clinical practice guideline division within our national academy. And in 2007, this was something that was really, really needed because we didn't have this understanding of standardized care for chronic sinusitis or guidelines to help, facilitate management of this disorder on a broader level. But what we learned is the disease complexity was much more deeper and broader than what we knew. And in 2015, there was an update, and it really speaks to when you see how many more authors are now part of this in the breadth and depth of their expertise, that our understanding was growing. And again, this was coming out of the American Academy of Otolaryngology, and there's a subspecialty society named the American Rhinology Society, and what we own is chronic sinusitis, and that is our task and our mission within the broader community of otolaryngology, is to facilitate and advance the care of patients with chronic sinusitis. And so the ARS, or the American Rhinologic Society, responded with this statement, the ICAR, the Clinical Practice Guideline Statement, in 2016. And this was a momentous undertaking, and what was done is all of the English-speaking literature was reviewed on chronic sinusitis, and chronic sinusitis as it relates to allergy, chronic sinusitis as it relates to asthma, pathophysiology, mechanistic studies that had been done, and et cetera. And this was the amount of authors that were required to do something like that. And so it was a momentous task. And what I would encourage you is, if there's two pieces of information that you want to read to have a better understanding of the current contemporary guidelines, it would be this guideline that I'm referring to, but also this paper that was published in JACI, which is really an exceptional paper that also looked at more specifically nasal polyposis. But it's a really nice contemporary review of where we are and where do we think we're going to probably go with the current data that's coming out. So the shift conceptually has been moved from sinusitis in 2007 to this understanding of rhinosinusitis. And what we're really talking about here is that it's not just inflammation within the sinuses, it's inflammation within the sinuses. And moreover, on a more broader view, it's not infection, as we all know, it's inflammation. And what are the drivers for the inflammation? And we'll come back to that in a little bit more. Sinusitis or rhinosinusitis, I'll use those terms interchangeably just for the sake of brevity and in terms of a talk. It's a common condition. It is approximately 30 million Americans are diagnosed per year, and much of the antibiotic usage in the United States is driven for a sinusitis or rhinosinusitis related condition. We know that there are different types of sinusitis, and we break them down from different ways, whether the phenotypic appearance of the disease, where it's the time frame of the disease. However, what's fortunate is that many of the symptoms are the same. But from a more pragmatic perspective, timing is a useful way of categorizing sinusitis. And so we have various subdomains of sinusitis based on time: acute, subacute, chronic, and then there's this other entity called recurrent acute, which is a little bit debated and a little bit more nebulous to define. However, they all share the same clinical features in terms of the history. And so what is new is the symptoms that we're using. Now, the symptoms are not new, but how we're emphasizing the symptoms is perhaps a bit new. And so the 4 symptoms that we're emphasizing are the ones that are listed here, primarily nasal obstruction, discolored nasal drainage, facial pain or pressure, and altered smell. The qualifiers here are, and key points to emphasize are, it's discolored nasal drainage. This is not clear rhinorrhea. This is yellow, green, whatever you want to call it. It doesn't actually matter the color, but it's discolored rhinorrhea. Moreover, the trend has now been, from 2007 till now, is this proof of inflammation. And I'll touch on this in just a moment of how we can prove inflammation, but that is key and is required now for the diagnosis. The specificity and sensitivity of history alone is not sufficient to make the diagnosis of sinusitis, and you must have some sort of proof of inflammation. What's no longer included is cough, fatigue, halitosis, malaise, these, quote, for lack of a better term, B symptoms. They are not part of the guidelines anymore. So these 4 symptoms are your only symptoms that are used for the diagnostic criteria of chronic sinusitis in the contemporary model. So proof of inflammation can come in a variety of forms. I think of it in 2 ways, and what's supported by the guideline is imaging and endoscopy. Now, us as rhinologists have the advantage of having endoscopes in our office readily available. We're familiar with it, we're facile with it. However, that's not always the case for other practice settings. So imaging does become an important tool. Inflammation on imaging can look in various different ways. This is an example of somebody with right maxillary sinus and partial ethmoid opacification on CT scan. This is somebody with more extensive disease involving all the visualized sinuses that I'm showing here in the one slice, so ethmoids and maxillaries. However, you can see the maxillaries are partially opacified. They're not fully opacified. This would be the most extreme example, where everything is opacified on imaging. There are subtle nuances that you can identify and pick up with review of the imaging, such as, within this doesn't visualize very well, but a double density sign can really indicate eosinophilic sinusitis, as well as potentially fungal sinusitis. On endoscopy, this is what we see when we look in the patient's nose with a nasal endoscopy. Polyps, there's pus. This is a left-sided nasal endoscopy. This is a clear marker of objective inflammation. So when we look at it from more of a schematic perspective, we have these 4 symptoms. We've broken them down by time, and these are the areas that we really want to focus on today, and in particular, it's chronic sinusitis. Now, one thing I must note that I neglected to say is that for the diagnosis, it is required that one of those 4 symptoms has to either be discolored nasal drainage or nasal congestion. So those are a must. One of those 2 has to be present, and then everything else is in addition to. So it's a total of 2 out of 4 symptoms must be present for at least 12 weeks or 3 months. Of those 2 symptoms that are present, one of them has to be either nasal congestion or discolored nasal discharge. So for the rest of the talk, I'm going to focus specifically on chronic sinusitis, because I think that's the area where we most overlap, that's the area where we most collaborate, and that's really the need for our patients to collaborate is in chronic sinusitis. So from an operational perspective, a definition of chronic sinusitis is defined as a symptomatic inflammation of the sinuses and nasal cavity greater than 12 weeks or 3 months. The problem is vast. The incidence is estimated between 1% and 5%, with a prevalence of around 12%. And when we look worldwide, we see that many of the industrialized nations experience chronic sinusitis. Now, what's very interesting about this is, if you look at U.S. and Canada, we are different in the overall prevalence of chronic sinusitis. But what's really interesting is the subtype or the endotype. And I'm going to come back to that concept later. The endotype of chronic sinusitis in North America is very different than that in China. And what we'll come to in a little bit is the idea of Th2 and Th1 mediated inflammation. And it turns out in the United States and Canada, it's really a Th2 driven process, whereas in Asia and Canada and Korea and the Korean Peninsula, it's more of a Th1 driven process. We don't know why that is, but we do see that disparity, and that's been shown in several large series. This is a really interesting slide to me from the perspective of how it affects society. We know that chronic sinusitis has deep effects on patient-specific quality of life. There's links with poor sleep, depression, poor work productivity, and school performance. Societal costs are significant, however. This is considered one of the top 10 most costly conditions to U.S. employers. And the absenteeism and presenteeism numbers were surprising to me. I didn't recognize and realize how high these actually were. And this is a significant issue for our work productivity in particular and patients' overall sense of quality of life. So comorbid diseases, if you compare chronic sinusitis, the impacts it has are deeper and broader than other diseases that we have often think of as being significant, such as chronic heart failure, COPD, or back pain. If you're not familiar with this questionnaire, this is the most well-studied and validated questionnaire that we have for chronic sinusitis. It is aptly called the SNOT-22, or the Sinonasal Outcome Test 22. The original version of this was the SNOT-20. This is the most recent version, and what was added was 21 and 22, which were subdomains specifically to patients' psychosocial status. So the last two questions, which don't show up very well here, are sad or embarrassed. And that's really showing this greater impact that chronic sinusitis has in patients' quality of life and symptom or quality of life outcome measures that we can capture. So this is something that in the UW Rhinology clinic we use for every patient does this every visit. We use this to track their care. We now know that this is out of a score of 110, that patients with a score of 34 or higher are excellent candidates for surgical procedures. Whereas when their scores are lower than 34, it's difficult to hit the minimally and clinically important difference, which is 10, and it's not 22 scores. So we use this, and so this isn't just a data point that we capture. It is actually becoming increasingly part of our clinical decision making, and I think as we move forward, it's just going to be emphasized even more. Comorbid disease is a very interesting aspect of chronic sinusitis, and this is where we work together. You know, if you look at patients with chronic sinusitis, and so I'm taking all comers. I'm not subtyping this yet on patients with and without polyps that are kind of phenotypes. But if you take all patients that diagnose with chronic sinusitis, approximately 5 to 40% of those will have concomitant asthma, and 35% of asthmatics will have chronic sinusitis. We know this. We know there's this relationship right here. If you look at the subtype, however, the phenotype of chronic sinusitis with nasal polyps, we see that those numbers actually change. And that much more of the patients that present to like a rhinology clinic with chronic sinusitis with nasal polyps, upwards to 70% of those patients will have concomitant asthma. And of asthmatics, fortunately, less of them have polyps. That is a different disease entity and requires different management options, and I'll go through that very soon. Allergy is very interesting, and allergy is the area where I think what we see in practice and what the guidelines show us and what the evidence show us is not always in line. And so this is an area that we know we need more evidence and more research on, and it's an area of future study. When we come to the pathophysiology of chronic sinusitis, this is the contemporary view. The simplistic view of decades ago was infectious, and how often do we hear, I have a sinus infection, I have a sinus infection, I have a sinus infection? And oftentimes that may be true, but more often it's inflammation and what's driving that inflammation. And all of these things are considered, potentially etiologic agents for the pathophysiology of chronic sinusitis. And more often than not, it's more than one of these in any given patient. The ones that I want to focus on today are certainly allergy, epithelial barrier, and immune function, because I think that's the area where we cross paths. I think that's the area where we really rely on you and your expertise to help us and have a better understanding, as well as the emerging treatment options. But there certainly are many other factors that are involved, and some other hot topics right now are biofilms and the microbiome. We're having a greater understanding of really this epithelial barrier and how the cilia function, and I'm not referring just to ciliary dyskinesias and cystic fibrosis, but just in general, is there functional changes in these structures that are different than those that are already described? So chronic sinusitis, when we look at it, what we're now recognizing is, what we all know, is these patients are not all the same. That this is the gap, and this is the limitation in our knowledge and in our evidence, is that we categorize many of these patients the same way. But we know they respond differently, and we don't know yet how to predict who's going to respond to whatever therapy we offer them, whether it's medical or surgical, but we know they're different. And then how do we figure that out? How do we navigate through that? And so what we've used historically has been the phenotype. And the phenotype is really, at its core essence, is polyps or no polyps. And we know that not all polyp patients are the same. They're distinctly different biologically, but how do we navigate through that? And so patients with polyps, these entities that we have described are AERD and allergic fungal sinusitis in particular. NARS is non-allergic rhinitis with eosinophilic syndrome. That's at least a rhinologic entity that we recognize and we discuss. And then there's these other ones of, how do we really characterize this? And really what it's moved to is this idea of an endotype. And so the endotype is the future of this. This is really understanding, this is precision medicine at its best. And what I alluded to earlier was that there's this difference in patients with polyps and patients without polyps, and whether it's a Th1 or a Th2 mediated process. And we do see that patients with Th1 driven process, these polyps tend to look more fibrotic, they're firmer, they're thicker, they're harder for us to move. So this is where we can help you, is kind of tell you what we see, what we feel, what we have to remove during surgery. And then characterizing the endotype is really going to be what moves us forward. In the Th2-driven polyps, we know that it's more of IL-4, it's IL-5 and 3, 13. That should actually be 13. And those polyps tend to look more blistery. They're more water-filled. They look like almost blistering polyps inside the nose. And so we see the differences, but this is really the move forward, is how do we characterize it at a biologic level. And so this is really the key for how we're going to move forward and collaborate and help really advance the care of chronic sinusitis. So chronic sinusitis without nasal polyps is what I'd like to first start with. This is just an endoscopic view looking into a patient's left nasal cavity. What you'll see right here, this is the middle turbinate, and this is the area that we spend so much energy on. This is called the middle meatus, so the osteomeatal complex is going to be right through here. This is where we spend so much of our time facilitating surgically the care of these patients. So the diagnosis, I've alluded to this earlier, it's 2 of the 4 symptoms we discussed for at least 12 weeks. You must have proof of inflammation. Obviously, there's no polyps for these patients. When we look at comorbid asthma, and this is the non-polyp patient, we understand that there's upper and lower airway are influenced by these common factors. That we know that eosinophilia, or eosinophils in particular, are a major driving factor for this, and the airway remodeling is hallmark. The summary of the evidence is such that we know that they coexist. We talked about that earlier. We know that asthma is often underdiagnosed in chronic sinusitis, and so these are the non-polyp patients. And we know they overlap, and we know that modification of one really influences the other. And there's evidence that it goes both ways. I think anecdotally in my practice, I noticed that if we get better control of sinusitis, it tends to help the asthma. I'm not sure if patients just have asthma treatment without sinusitis treatment, that the sinus-specific symptoms alter. I'm not referring to biologics yet, but just in general asthma-directed therapy, whether it's bronchodilators or steroids, whatever it may be. But we do know that there are relationships there, and that's really, again, that synergy that we can offer patients. Allergy is less well defined in how it affects chronic sinusitis, and I think this is, again, where we see in practice and what we do every day is somewhat divergent from what we see in here in the literature, and it really shows a gap in our knowledge of really what we need is more high-quality evidence, that these are all level D studies, or category D studies.
You know, your last slide said it was eosinophilia was common in that. I think it's just the opposite. Eosinophilia is in the Th2-driven one, and the one with polyps. So is that a mistake, or I don't see that with when they don't have
I think it depends
polyps.
on how we're talking about eosinophilia. If you're talking peripheral eosinophilia, or if you're talking tissue eosinophilia.
Yeah.
And so what we have done is we've taken biopsies, tissue biopsies of patients with chronic sinusitis, both with and without vasopolyposis, and have seen abundance of eosinophils in those biopsies.
In these biopsies?
These biopsies,
Really?
it's tissue eosinophilia, though, which may be different and mechanistically than a peripheral eosinophilia. And so these are the gaps that I don't know the answer to.
But this is Th1 driven. This is not Th2, and Th2 is the eosinophil
Right.
associated
This
one.
is the
So
gap.
Something's weird.
This
there.
is the gap, and that's where, so that raises the question: is that relevant? Is because there's eosinophils in the tissue, is that relevant? What do we do with that? How do we interpret that? And that's what we don't know.
Well, I think that is the most relevant thing, because the ones with eosinophilia obviously respond to steroids, and this one doesn't. You know, nasal polyps with nares and with eosinophilia almost always respond very well to steroids, whereas this one doesn't. So that's a gap for me. I don't understand that.
Yeah, I'm with you. I don't understand the mechanisms on it. These are the data points that we have, and you know, where we move forward. This is a great point of how we need to collaborate and work on this and understand these points. Innate immunity is interesting as it relates to chronic sinusitis. We know that there are various facets of innate immunity that are implicated in chronic sinusitis. In particular, it is the antimicrobial proteins, something called pattern recognition receptors, and I'll touch on that in a moment. And you know what we've seen in various small, mostly animal model studies, have been that there are these various factors that have been implicated in chronic sinusitis, particularly in this model, meaning the non-polyp model, and that lysozyme levels, factor B levels, and these pattern recognition receptors in particular. And what we have seen is that there are changes in the function of these pattern recognition receptors in particular. And we think that there is some evidence that these immune mediators are differentially expressed. And if you look at healthy controls versus chronic sinusitis, non-polypoid patients, that there are up and down regulations of these various factors that are different than otherwise healthy controls. Now, what that means, I don't know. It is preliminary data, but it is data that's advancing us. And this is that exciting time where we're in, is that we do have this data, or these data. And how we move forward with it, how we interpret, how we use it, I don't know. That will be determined. And it also is within the epithelial barrier. And this is really a hot topic, at least in the rhinology space right now, is, we recognize that the epithelial barrier is a mechanical barrier. We recognize that it's biologically active. But how it interplays with chronic sinusitis is not known. But there are various factors in the epithelial barrier, whether it's the mucus blanket, whether it's the epithelium itself, and how it interacts with the development and secretion of interleukins, eotaxins, cytokines, reactive oxygen species, all of these factors. And so we know that the respiratory mucus is important. We know that mucociliary clearance is important for a variety of reasons. And we know that the epithelium has these connections and these junctions and these interactions with various receptors. But how we interpret it for patients with chronic sinusitis is really another area that we have to continue to research. And there are some newer agents that are coming out that are specifically targeting and looking at these structures. They have not yet hit clinical practice, but this is something that's coming for us. And the endothelial cells also have these pattern recognition receptors. And so we think that this is maybe a really important area because it may be somewhat of a gatekeeper, if you will, to the inflammatory milieu that occurs in the mucus and the immediate surrounding areas of the mucosa, and that the cyclic cascade can ultimately develop and perpetuate in these spaces. So, the conclusion on this is that we know that there are factors within the epithelial barrier and innate immunity. We think they interact with each other. How it's going to change our clinical practice is yet to be seen. Immunodeficiency. So patients, we know that patients with refractory chronic sinusitis, so these are patients that have failed medical therapy, and these are patients that have failed medical therapy, that many of these patients, and actually upwards of 50% of these patients, can have an undiagnosed immune disorder or deficiency. And so what that is, and this message is really to us, in that if we have patients that are not responding to what we think is appropriate medical surgical care, comprehensive complete surgery, if we have not engaged an allergy immunologist opinion on this, this is where we, as the rhinologist or otolaryngologist more broadly, this is the message to us, is that we need to continue to working alongside with you folks and how to manage these patients, because it is a factor in some patients. Chronic sinusitis with nasal polyps. Similar view, this is showing polyps in that middle meatal space. The diagnostic criteria are very similar. However, we must have polyps for this one. So this, again, is a gap for us. It's just that phenotype. And so we know the biology, which we're alluding to, is very different. But this is where we are in terms of the guidelines and recommendations. So we know this concept of the unified airway theory. This has been described and studied. Somewhere in the order of 60 to 70%, upwards of 60 or 70% of patients can have concomitant lower airway disease or reactive airway disease in particular. We talked about eosinophils in particular for this one, and for sure this is the idea more broadly of peripheral eosinophilia, common inflammatory mediators, Th2 activation, and epithelial barrier matters. We know that, and this is what I was alluding to earlier, that with better control of chronic sinusitis, patients do better with their asthma symptoms. They have improved asthma severity scores, their peak expiratory flow, less steroids, less ER visits and hospitalizations. I'm not sure always that the converse is true, that untreated sinusitis but appropriately or aggressively treated asthma affects sinus disease. I don't necessarily think, and that's my opinion, I don't necessarily think that's always true, but I think that this is true, that we have to do a good job with the sinus issues, and then globally their health, whether it's sinusitis or asthma, tends to improve. Not cured, but improved. So, this is our guideline. So this is what's being given to the otolaryngologist around the country, is that we should be screening for asthma in patients with polyps. And I think many of us know that inherently, but this is the first time this has been put out in a consensus statement or a guideline, at least in the otolaryngology literature. So this was a big step forward in really kind of emphasizing this need for collaboration, this need for multidisciplinary care, this need for continued advanced medical therapies and collaborative care in particular. So the associations with nasal polyposis and allergy, we've talked about Th2, mast cells, basophils are also increased in polyp tissue. So again, this is that idea of tissue samples versus eosinophilic inflammation, which is common in both. And so when it comes to allergy in patients with chronic sinusitis, this is another one of those gaps, again, that may exist between practice and what's available in guidelines and literature. And so it's considered currently in our guidelines an option for evaluation for allergy in patients with polyps. I know in my practice I don't really view this as an option. I think it's an important part of the care, and this is where Drew and I work closely in particular in our combined clinic. And that, to me, it does matter. It does matter for, one, a better understanding, a better idea of counseling patients, discussing options and treatment. Patients, we live in an environment where cost is increasingly important, and why that's relevant to me is surgery costs a lot of money. And so giving patients as many options and palatable options as possible is something that we all strive for. And so I think this is an area where, me personally, I tend to emphasize it, but the guideline calls this an option, and what they're speaking to is limitations in the available published evidence. And so evidence-based medicine for the management of these two entities. When it comes to innate immunity in patients with polyps, we think there are associations with antimicrobial proteins and those PRRs that we mentioned earlier. The evidence is conflicting on this, however, in patients with polyps. And I think this is, again, kind of showing more for the patients with polyps, the Th2-driven process, and less of the epithelial dysfunction, as well as less of the innate immunity component in patients with polyps. And this is, again, coming back to the ideas of endotype in this entity. With immunodeficiency, it's much more limited with immunodeficiency and how it affects nasal polyposis. It doesn't mean there's no role. It just means that the data that we have, the published data we have, is less suggestive or more limited than it is in patients without nasal polyposis. I want to touch very briefly on a very specific disease entity, and that's AERD, one that we work very closely together on. And so AERD, the old term for this was Samter's triad. We know that about 10% of patients with polyps are at risk, or the prevalence of AERD in patients with polyps about 10%. Onset typically in the 4th decade, however it can occur at other times in life. We believe that this is a skewing toward the leukotriene metabolism pathway and downregulation of the prostaglandin pathway, therefore results in elevated IO5 and eotaxin. Pro-inflammatory eosinophilic airway inflammation, and this is probably the prototype for collaborative care in that surgical treatment matched with medical therapy is really the hallmark in the contemporary treatment of this. There are genetic polymorphisms that are likely involved with this, and why we believe this is the case is that there are certainly elevated leukotrienes, which we know, but where there's also elevated quantity of the receptors and affinity of the receptors. So it's not just a leukotriene change, it's also a receptor change. And the throughput in the prostaglandins has been altered. And so, we manage this mostly based on history. We can't do a nasal provocation challenge if the history is uncertain or the diagnosis is uncertain. But this is, again, where surgical therapy and medical therapy, whether it's aspirin desensitization or other options, are really the essence of collaborative care. So what I'd like to move into now is really kind of contemporary management strategies. And what I'm going to emphasize is the surgical piece, because I think that's the area that I can share with you, and what I learned from you is the medical piece. And I'll touch on a few of the medical aspects. So we've talked already about the history and supporting diagnosis and using quality of life outcome measures. The imaging modality of choice. So if you have a patient in your practice that you feel meets the diagnostic criteria of chronic sinusitis based on history, the 2 or more features for greater than 12 weeks, the imaging modality of choice for this is CT. Still to this day, we often see some patients get plain films or MRIs, and we really want to use CT scan. And the reason why we use CT scan is for several reasons, and maybe some of these are evident, maybe some of them aren't. In the CT scan, we have studied extensively and called the Lund-Mackay score in terms of its specificity and sensitivity for diagnosing sinusitis. We know it doesn't correlate with quality of life outcomes, so that's a limitation of it. But also, a little bit more selfishly, is we do use this for surgical navigation. So there is a benefit beyond the diagnostic aspect of using a CT. It's also used at the time of surgeries for surgical navigation capacity. So the one that we offer, or that we order at the U, is the CT maxillofacial. It could be a CT sinus or orbit protocol, but the idea is it's thin cuts, 0.6 millimeters without contrast. And this is used, one, again, for diagnostic purposes, mapping of disease, but also surgical planning for us. And so the
What's
shift...
a gantry tilt?
Gantry tilt, the gantry is the actual device that you lay in.
Mm-hmm.
And the gantry tilt, often what the techs do in the radiology suite is they tilt the gantry to be in line with the palate so that you have perfect axial and orthogonal views. However, if you put a gantry tilt on the CT scan, it's incompatible with surgical navigation software programs. We can't use it, so we have to repeat it. And so that's obviously cost, radiation exposure, etc.
Do you have a specific protocol where those cuts are just like through the OMC area and like 2 or 3 millimeter cuts otherwise? I mean, just or do you just do the whole?
Great question. You know, I think perhaps what we do, again, is a little bit more selfish because we're using it for surgical purposes. So our protocol is 0.65 millimeter cuts from vertex to maxillary teeth or dentition. And that's because we don't know what we're going to need to do. Are we going to need frontal sinus surgery? Is it sphenoid surgery? Is it all surgery, comprehensive surgery? So for us, having that fidelity in the view is really important. Now, with that being said, if the patient has outside imaging and it's 1 millimeter cuts, 2 millimeter cuts, we'll often use that. It's not preferred, but we'll use it. But we balance that by saying, well, that's cost, it's radiation exposure, it's time. That's not probably justifiable for that clinical context. What we don't want, and what we often see is screen protocols, which are 5 millimeter cuts. That's not very helpful for us, both from a diagnostic perspective, disease mapping perspective, and a surgical planning perspective. So some sort of a variation like that. So the shift has been maximal medical therapy to appropriate medical therapy. And so that was the precedent in 2007. This is the era where if you had sinusitis-specific symptoms, you got an antibiotic, and then you came back. And then if it wasn't symptom relief, you got another one, a longer one, a stronger one. Maybe we'd add prednisone into it. And so that era is gone. And so the era now is appropriate medical therapy. And so what does appropriate medical therapy mean? And appropriate medical therapy is this. Now, this is a guideline, obviously, and this is a group. We still have limitations in our knowledge and the evidence. But for patients without nasal polyps, we use saline irrigation. This is that neti pot or the sinus rinse bottle with intranasal corticosteroid sprays. You can choose. There's no superiority of one over the other in the data. It could be fluticasone versus mometasone, budesonide, it doesn't matter. We're talking nasal sprays. I'm not talking irrigations at this point. And then, what do we do for additional medical therapy? And the guideline and the evidence says that antibiotics are an option and oral steroids were insufficient to make a recommendation. This is a problem. And this is a problem because from a payer's perspective, from an insurer's perspective, they will not authorize a surgical procedure unless an antibiotic's been tried. Now, how long that needs to be used is variable depending on the payer. Most payers are around 2 weeks. I think that's more often than not what I see. Some are closer to 3 weeks. What type of antibiotic, how long the antibiotic, what dose of the antibiotic, these are areas we just don't know. And so I think the best practice here, given we have a little bit of a difference or a gap here between what the evidence is telling us and what we're beholden to from an insurance or payer's perspective or appropriateness perspective, is this is, I think, where, again, partnership and culture really helps us. So endoscopy and endoscopy-driven culture really can help guide this. And that our current practice is that if a patient has chronic sinusitis without nasal polyposis, what we prefer to do is have the patient come in for a nasal endoscopy and perform a culture. The culture then helps guide antimicrobial therapy. Now, let's say the culture is negative. That's the most challenging one to do. Some of those patients may be viral, and we don't routinely test for viral in our clinic. But let's assume for a second that it's not viral, and that maybe the culture wasn't capturing the bacteria, so the selection, the aspiration technique we're using, maybe the microbiologic method we were using, or maybe they had just finished antibiotic given by their primary provider for a few days, and so the culture comes back negative. Those are challenging.
How are you obtaining your cultures? Are you just going in the nose, or are you really going in the sinuses?
Great question. I'm going to show you a video in just a moment on that. On patients with polyps, the guideline's a little bit more clear. So saline irrigations, again, are recommended. It's a minimum of 1 month. It's twice daily. These are high volume, low pressure irrigations. I'll show you a bottle in a moment. We don't typically emphasize the neti pot so much, but the Neomed sinus rinse bottle. The neti pot is actually a hard plastic, or the original versions were kind of a ceramic pot, and it kind of requires a little bit of an awkward technique to do it. The sinus rinse bottles are 240 milliliters, or they're a squeeze bottle. The benefit of that is, one, just patient positioning doesn't have to be is a little bit clumsy, but it also allows the patient to control the force being put into the irrigations. One of the major compliance issues we see with irrigations is that with the neti pot, if patients can't control it, it just gets dumped in. And many patients will say, I'm not doing that, I don't like it, it's uncomfortable. And it's because they can't really control it. But if you give them the squeeze bottle, they have more control. They can choose how hard they can squeeze, they can choose their position, they can take breaks from it and stop. And so I think from a compliance perspective, it offers patients a greater degree of control in their compliance. So saline irrigations, intranasal corticosteroids, this is again fluticasone, omeprazole, whatever you prefer. Nasal spray, not irrigations yet. And then 2 to 3 weeks of oral corticosteroids. We don't know what's the dose. What do you start at? What do you taper to? How long do you do it? Should it be 10 days? Should it be 14 days? Should it be 21 days? We don't know. We don't have the answers on this. Our practice at the U is a little bit physician specific. I'll tell you what my algorithm is 30 milligrams for 4 days, 20 milligrams for 4 days, 10 milligrams for 4 days. I don't have an answer for you why I do that. I don't have a great answer. I don't have a data-driven answer for why I do that. To me, in my mind, conceptually, it balances risk and harm. I don't prefer to go to 60 or 80 milligrams, because I've seen that, 60, 80 milligrams of prednisone. And I'm not talking in the flares and acute asthma exacerbation. I'm talking about a patient with chronic sinusitis that comes to my office for sinusitis-specific symptoms. Maybe they're having asthma symptoms, but they're not there for an asthma exacerbation. They're there because of nasal symptoms. So that's the algorithm I use, and I think it's up for discussion. Antibiotics are considered an option in patients with nasal polyposis. That's a change. That's a major change. We don't have to use antibiotics with patients with nasal polyps. And I think this speaks to what we're referring to either with the eosinophils. This is a greater appreciation of the eosinophilic or the inflammatory-driven process in chronic sinusitis with nasal polyposis. However, what I will say is if an antibiotic is chosen for, because these patients can get infected. It doesn't mean they can't have infection. It just means that we're emphasizing inflammation now. We're not emphasizing infection anymore. Still, culture would be preferred. And if you decide to use an empiric course of antibiotic, macrolides would be preferred. The duration of therapy would be 3 weeks. And that is based on the most current evidence that we have available. So macrolide therapy for 3 weeks. In our practice, we tend to go with clarithromycin for 500 milligrams. We do a BID for 21 days. And so the guidelines support that. It's a little unclear exactly, in polyp patients, do you have to do that? This is, again, some pushback we get from payers. They haven't been on an antibiotic. We submit them our guidelines and say we don't need to give them an antibiotic anymore. That has changed. That is an area that's a practice management that we have to struggle with. Yeah.
So as a practical point, I would guess 90% of these patients come in having been on 5 different antibiotics already. But what drives you to add an antibiotic given that?
I struggle with this.
Like a lot of these patients, you'll never get to the ostia because their polyps are so big. Do you use cytology at all, or is the thought, are they going to respond to this or they're not?
This is a great question and something I struggle with every day. Because what they often have come in is on a Z-Pack, maybe 2 Z-Packs. 5 days, is that enough? The guidelines say it's not enough. The guidelines would say it's, if we're going to use an antibiotic, it would be macrolide for 3 weeks. I don't know the answer to that. And so what I do divert back to is the endoscopy. What's the endoscopy showing me? Is the endoscopy showing me pus or is there no pus? If there's pus, I do culture it. Now, getting to what the question was earlier about how do we get that, the days of aspirating and putting a trocar in, the sinus are gone. We don't have to do that anymore. What we need is middle meatal. And so that's that space I was referring to. We spend so much of our time and emphasis on. We actually don't have to get the culture directly from the sinus. We can get it right from the outflow of the sinus. And that's been studied, where they actually did puncture techniques, did an aspiration culture, and compared it to the outflow, and the culture microbiologic data was the same. And so what we do is we get into that space, the outflow space, and sample it right there. And we can do that in the office with endoscopy. What we don't want to do is just take a nasal culture, a nasal swab. We know that that doesn't correlate with sinus cultures. But middle meatal and outflow near the ostia, as close to the ostia as we can get, does correlate. So surgery, the goal of surgery is safe, appropriate, and complete surgery. And I can't emphasize the complete surgery. This is where we have to be better. We have to do complete surgery. Just doing surgery isn't an answer. And that's why we see failures in sinus surgery, or recidivistic disease. And I'm not saying cure, but why we fail, why patients need revision surgery. Why do we think surgery helps? We think it permits ventilation, aeration, more effective mucus clearance or mucociliary clearance, but perhaps and likely the most important of all of this is delivery of high-fidelity, high-quality therapy to the sinuses, not topical therapies. And so what I want to show you an example of right here is this is a patient of mine that has chronic sinusitis. This patient had a unique form called barosinusitis, so their imaging is a little different. But what I want to kind of just show you is what our goal is for comprehensive surgery. So what I'm working on right here is in that middle meatal space, and I'm really going up into the frontal sinus. The most challenging technical part of this whole procedure for us is the frontal sinus. The angulation, the instrumentation, it is the most challenging. We use various angled scopes, 30 degrees, 70 degrees, curved instruments to get into this. It is unnatural feeling. It is working in a 3D space or in a 2D world. I mean, we're looking on a flat 2D screen to operate a 3D space. Conceptually, technically, it's the most challenging. And so, but what we want to do is if we're going to go into that space and do sinus surgery in that area, we want it to be comprehensive and complete. And so the anatomy in this area is very challenging. And we use various techniques in terms of looking at our preoperative imaging. This comes back to that idea of a high-quality CT scan to facilitate our surgical planning. And then making sure that we have this nice hemostatic environment that we can operate in with our curved instruments. This instrument right here is a navigation probe. It's showing me and verifying me where the frontal outflow is. And right here I'm going to pause directly on the anterior ethmoid artery. The anterior ethmoid artery is a division of the ophthalmic artery, comes right across the ethmoid skull base and goes back intracranially. So that's something we have to find, and that's where imaging helps, or the navigation and the high-quality imaging helps us. So the dissection continues through these kind of various partitions and cells. The ethmoid sinuses in particular are honeycomb. There are all these tiny little partitions in them. And just opening them up is insufficient. You have to completely remove them from orbit to the middle turbinate up to skull base. That's high quality effective surgery, that's complete surgery. And so ultimately what we want to get to is we want to be able to remove all these partitions. And again, it comes down to the idea of really improving access for topical therapy. If all these little tiny partitions you're seeing me remove during the surgery aren't gone, delivery to that frontal sinus will not be appropriate, will not be sufficient, it'll be inadequate, and therefore the failure is really a technical failure. It's a surgical failure. And that's where we as rhinologists and otolaryngologists have to continue, and we strive to be better in making sure we deliver high quality, comprehensive surgery. And so towards the end of the surgery, this is kind of what we want to see. We want to see that we kind of have a wide opening in the frontal sinus. There's still a little bit of a partition right there that I'll finally remove. That F is showing the frontal sinus, and that's what we want. That's clear delivery of medication up into the frontal sinuses. This should be our goal every time if we're going to do comprehensive, all four sinuses sinus surgery. The failure rate in patients with non-polyps is about 10%, but it's almost 40% in patients with polyps. And so some of this is biology, indeed. Some of this is working collaboratively in comprehensive medical therapy, but some of this is also surgery, and much of this is our surgery and our technical abilities. This is a patient I saw recently that's had 3 previous sinus surgeries. And on the surface, this doesn't look too bad. There is aeration in the sinuses. There's some partial pacification or mucosal thickening in the maxillaries. But if you look right here, it looks different than the opposite side. And this is because the middle turbinate wasn't handled appropriately during the surgery. This is a technical failure. This is called a lateralized middle turbinate. Also, the uncinate wasn't removed completely. You can look at the opposite side and just see the difference in the scan. These are nuances, but they're important. Both of these will not allow delivery topical therapy in the maxillary and the frontal sinuses. Now, with that being said, the maxillary doesn't look bad here. The reason it doesn't look bad here is there's a hole behind that was not supposed to be present, that was artificially created. So there is some topical therapy going in the maxillary sinus, but it wasn't a standard technique to get delivery into that area. This is the same patient in their nasal endoscopy. This is his left side. So this is the side we said was better. This is the side of what I would consider, this is limited sinus surgery. This was maxillary and only part of the ethmoid. But this is well done surgery. It's open. It's delivery topical therapy. I don't see any mucopurulence. There's minimal mucosal edema, but certainly no polyps. This is what we're striving for in post-op care. This is the patient's right side, and you can immediately see there's this stringy, kind of discolored mucus that's coming out or filling the nose. And if you follow some of these mucus streams up, you'll see is right up here. This is the sphenoid. That's not been opened. But this is the middle turbinate. That's right up here. That's the middle turbinate. And that middle turbinate is in a completely lateralized position. And when we're going to remove the mucus here in just a moment, and as we're removing the mucus, you can follow that, and it'll go right up into that space that should be open, what we want to be open for delivery of therapy. So this is how I aspirate mucus in the office. This is a suction trap. It's like a Lucan's trap, specifically designed for the sinuses. And so again, I'm not pushing directly in the sinus here. I don't need to. I just need to collect it that's coming directly out of the sinus. And so this is me kind of just suctioning it right out of the sinuses in those areas. Other forms of failure, this is a patient that has still burden of disease in the ethmoid and the frontal. The maxillary sinuses and the sphenoid are not horrible. There is some mucosal thickening, but we can really see here on the scan all of this is all bony partitions that were left behind. This patient had 4 previous surgeries, and they were all described as frontal sinus surgery. We didn't do a good job as otolaryngologists removing these bony partitions despite documenting and billing for a surgery in this area. This is a failure. And so these are the technical failures that we need to do better on. This is the same patient I took to the operating room, and this is now showing up into the frontal sinus. And one of the ways that we have to help try to mitigate our failure risk, beside doing comprehensive and complete surgery, are these newer tools. This is the mometasone implant device. Brand name is Propel. So this is a drug-eluting implant that lasts 30 days. It's made of vicryl suture, and it releases mometasone over a titrated basis for the subsequent 30 days. So we can put this directly in the frontal sinus. And we have now data out to 2 years showing that the frontal sinus patency rates are significantly better than when we don't put in these implants. The current indication for these implants, in my mind, are in patients like this, which has aspirin-sensitive disease. These are patients with severe nasopolyposis. This patient's 1 month out from surgery. I just saw her last week. You can see the implant. It's still somewhat there. It's degrading. Whatever's left at her next post-op visit in a few weeks, I'll take out. But we have clear patency in the frontal sinus. This was a top-to-bottom, outside-the-nose kind of polyp patient. So all the polyps have been removed. I put this drug-eluting implant in directly into the frontal sinus. This is the skull base cleanly dissected out, looking back into the sphenoids and maxillary sinuses. This is what we're looking for each time, what we want to do. And it's challenging. It's really difficult to do for a variety of technical reasons and disease-related reasons. If all else fails, we do have another procedure called a draft 3 or a low procedure. And this is where we can connect the frontal sinuses. Why we think this works is we believe what it works is again, delivery of topical therapy. It's given the maximal dimensions that the frontal sinuses can be. So in this procedure, what we're doing is we're actually removing all the bone that separates the frontal sinuses and all the bone that's right here in the nasal frontal loop. This is connecting the frontal sinuses. Believe it or not, this is well tolerated. This is an outpatient surgery. It's about 2 to 3 hours. Patient pain reports are not significantly different than patients undergoing traditional sinus surgery. It's a little worse, indeed, a little more crusting, a little bit more dripping type bleeding after surgery, but it actually works really well. The Australians do this almost at the first surgery. Not quite first surgery, but if they've had one surgery and they failed, they go on to the draft 3 more often than not. The philosophy and the culture in the United States is a little bit more constricted, a little bit more reserved. There is some geographic and institutional bias on this. However, it is a procedure that is available. It is something that we do. I don't find that I do it often in my practice. Maybe less than 5% of the time do I need to go to this with the kind of contemporary techniques we have, these drug-eluting implants, using topical therapies. More often than not, we don't have to go to this, but this is a technique that we can have. And you can see here that the frontal sinuses are disconnected from left to right.
Is that a drill with a burr at the end that you rub it away with?
Yeah, it's a 3mm diamond drill that rotates 30,000 times a minute. So it's a high-speed drill. This is what they look like post-op. This is about 6 months post-op with a connected frontal sinus and what the imaging looks like. And all of this is for this. This is the delivery of the topical therapy. There have been many things discussed, described, and you probably hear in your office that patients try. Many of them are not supported by evidence. Many of them have not been researched. The ones that I will emphasize in particular are steroids, and we do use antibiotics. The key is the irrigation-based therapy works well for patients that have had comprehensive complete surgery. Patients that have never had surgery, not a great choice. Now, I'm not talking saltwater irrigations. I'm talking additives to the irrigations. The delivery into the sinus penetration is very minimal, if at all, in patients who haven't had surgery. So these are patients that have had surgery. Antibiotics can be used, steroids, silver is being used, xylitol, manuka honey, betadine, etc. Many of these things are not supported by evidence, but the one that we lean on the most by far is budesonide. We use budesonide. You can use the Respio, or you can use a compounded version of it. We tend to use the 0.5 milligrams in 2 mLs, diluted in 240 milliliters of nasal saline. We have the patients do that twice a day. We have safety data now up to 2 years out showing that patients can use this on a daily basis. This has been by far the most game-changing medication, treatment, therapy that we have to the management of chronic sinusitis. So lastly, I just want to touch on the future. The future, I think this is where you guys are teaching us. You guys are leading the way, and you're leading us with the better understanding of the mechanisms involved with chronic sinusitis, defining the endotypes, helping us search for biomarkers or defining biomarkers, and I think this is the most hot topic in rhinology currently, biomarkers. Various things have been discussed and described, including the ones listed here, periosteate IL-5, the tissue samples that we talked about earlier. And really this idea of the endotype is this great definition that came out of that Jackie paper I mentioned earlier, which is the subtype of disease with unique pathomechanisms. And that's really what we're looking for. And we want to understand better this cytokine profile, and whether it's a neutrophilic profile or an eosinophilic profile. And it's been exciting because we've had the introduction of various drugs that target these. The most widely known is probably omalizumab. Mepolizumab and resolizumab are a little bit newer, but have a different mechanism than omalizumab, which is targeting IgE. And then dupilumab is the more recent development. None of these are currently indicated for nasal polyposis. And so this is the area where we really rely on you and where we lean on you and value your expertise, is that you really guide us in the choices of these medications and these drugs. I want to show you an example of a patient that was on biologic therapy. So this is the pre-biologic therapy chronic sinusitis. She's had 15 sinus surgeries, 15. She suffered from chronic sinusitis for about 45 years. She's been on, when I met her, she was on prednisone daily, 40 milligrams, and she'd been on that for 10 years. She was on oxygen therapy and came in my office in a wheelchair. So I think I immediately called, I think it was Drew on this. Drew, this patient's out of town. She's from 4 hours away. I need you to see this patient. Can you get her into the office and see her today? So ultimately, she was deemed to be the best candidate for Xolair. And so this is her after Xolair. Nothing else changed for her except for she's off prednisone, by the way. So she's off prednisone, off oxygen, and on Xolair only. And so this was really remarkable. I wish this happened all the time, and it doesn't happen all the time. And particularly with Xolair, we're going to see better. I think we're seeing better trends with mepolizumab and resolizumab. But this is really one of those success stories, and so this is really inspiring and helps us forward to understand who are good candidates for this, who aren't good candidates for this, when should we use it, when should we not use it, how long do we use it, all of those types of questions, particularly in the chronic sinusitis domain. I don't want to call it the exception, but it is not often that we see that great of a response, and this is a patient that didn't have as great a response on Xolair. This is a similar patient that's had 4 previous sinus surgeries. He is on omalizumab, and he continues to have this kind of blistering edema throughout all of the sinuses. You can see this kind of little opaque mucus all the way through as well too. He is better, but not as striking as that last one. And so why him? Why did he not respond as well to her? These are the endotypes that we need to further characterize.
Just as a practical point, do you recall if the first patient happened to be very atopic and had difficult to manage asthma, or did you get the Xolair sort of compassionate need trial? Do you remember?
I will defer to Drew on that.
They had severe asthma, that's why I got it approved.
Yeah, because obviously it isn't approved for this otherwise. And what's your feeling about local IgE production?
So I think it's an interesting topic. It's something we talk a lot about because we see the patients get skin testing or serum testing and come up negative, and we're like, they have some response to either oral antihistamine or topical therapies, and we're kind of scratching my head, thinking about local IgE production inside the nasal cavity. So I am starting to use antihistamine-based irrigations in my practice as well too. It's new. I don't know what's going to come of it, but to me, when we see azolastine and its synergistic effects with intranasal corticosteroid sprays, it really makes sense to me. I don't have the data to support that, but I am using it on patients budesonide and atopic for an antihistamine mechanism.
So I think it is worth, though, thinking about the non-IgE mechanism of Xolair as well. We do have a few patients, one in particular I remember that I shared with Greg, who, no asthma, no ATP, but bad sinus disease, responded very well to Xolair. It's hard to get it approved.
Yeah.
But once you do, you can make that.
I mean, obviously, if it ultimately is an indication, I'm sure it's something you'll look at when you send things off for pathology.
What we've been doing together, it's hard to know with this changing healthcare environment and landscape too. And what we've done is we're trying to give each patient as many options as we can. And what's best option for the patient is sometimes hard to know. And this speaks to other things that can come down the pipe here. And so this is a very interesting. This was in a paper also in Jackie looking at a transcription factor called GATA3 DNA enzyme. That was the actual drug. But GATA3 is a transcription factor that actually is upstream of many of these factors that are involved with the Th2-driven response. And so IL-3, IL-5, IL-13. And so this is an upstream target. And this in mouse models has shown some promising effects for mediating the phenotypic features of chronic sinusitis in a mouse model. So I think the future directions for us from a surgical management perspective is how do we optimize surgery, and so what we're looking at in our group is using navigation and navigation-based technologies to provide real-time feedback to surgeons during their dissections, real-time intraoperative CT updates. So patients, there is technology available to get CT scans in the OR. As you can imagine, it's costly, it's cumbersome, it's bulky, it's radiation exposure. So we're actually, we work with the computer science and electrical engineering department at the UW. We're using the same technology in the self-driving cars called SLAM. And we're using that same technology to, as we move our endoscopes and instruments through the surgical field, which is navigated and captured, we can actually do an augmented reality and real-time update of our imaging data set to show completeness of the surgical dissection. So that's where we're heading, and we have some grant proposals out for that right now. I started this by saying I get to work with some really amazing people, and I want to acknowledge Matt for really putting this all together in terms of, we went and saw the total eclipse together, and I really think Drew and Mahari, you guys were there in spirit, so hopefully next time you'll actually be there, because it was a great event. Ultimately, the nose is challenging. I think it's daunting. And so this, in the foreground here is the hull bag, which is where you carry up this 5-day multi-pitch ascent of the nose, and it's just daunting to me, and it's humbling to me, how difficult this work is. But really, at the center of this is patients like Trina. I really want to thank her for allowing me to use pictures of her and her story as kind of a mechanism how we can collaborate and work together to allow patients to really pursue their dreams in life. So I thank you for your attention and your time, and it's been really a pleasure and an honor. Thanks.
How much can you actually remove if your goal is to get access to diseased tissue? I mean, you talked about moving, getting the frontal sinuses together. How much more can you remove?
You can remove from the orbit. You technically can remove from orbit all the way to septum. We don't prefer that because of olfactory outcomes. So from orbit to the middle turbinate, all the way up to the base of skull, from the very front part of the frontal bone that you kind of feel right here, to the back frontal table where the brain would sit, all that can go.
Wow.
And there's no functional consequence of that, as long as it's mucosal sparing.
As long as
mucosal sparing. So decades ago, why we were really not good surgically was we were not doing mucosal sparing techniques. We were stripping mucosa.
Right.
And so then these patients were having squamous metaplasia and non-pseudostratified columnar epithelium, and that's why the outcomes were abysmal at that time. But since we moved into the era of endoscopic mucosal sparing techniques, there's no excuse to bring that anymore.
the purpose of the sinus is simply to make the head lighter.
That's an age-old debate. I don't know the answer to that.
Hey.
It's interesting.
Yeah.
I can't imagine taking that video. Although I think I'd rather have that done than spend 5 days on the wall.
Yeah.
I love that. And they hang hooks.
Not too bad. How about you?
Somehow I feel we're not going to